Okay, I'm just gonna wait one more minute before getting started. Okay. Good morning and welcome to session 2, Defining Priority, Ageism and Ableism in the COVID-19 Pandemic by Alana and Elizabeth. My name is Georgia and I will be moderating this session. So before we begin, I would like to remind you of some important logistical information. So please note that this Zoom session is being video and audio recorded. And if you do not grant consent for this, please feel free to leave the Zoom meeting. We kindly ask that you mute yourself when you are not speaking so as to minimize distractions. And we recommend that viewers put the screen in speaker view so that they can see the presenters at all times. If you have questions or comments during the presentation and access to chatting capability, please send them privately to me, the moderator. My Zoom name is Moderator Georgia, and you can select to send them to me by selecting my name, Moderator Georgia, in the 2 fields of the chat box. And there may be times throughout the presentations where the presenters will ask for comments from the audience. During these times, you will not use the chat feature. Instead, either please raise your hand in front of your video or come up to the D10 to indicate that you would like to speak. And then I will call you by your name or room number, at which point you can unmute and speak to the presenters and the rest of the group. And now I will turn the presentation over to our excellent speakers, Alana and Liz. So take it away. Thank you.
Hello, everyone, and welcome to our presentation. During our presentation entitled Defining Priority, Ageism and Ableism in the COVID-19 Pandemic, we will be focusing on the impact of COVID-19 on elderly people and people with disabilities.
We will be covering topics such as vaccine production, clinical trials, quality-adjusted life years, also referred to as Qualis, sequential organ failure assessment score, also known as SOFA, and allocation of scarce resources such as ventilators.
To start our presentation off, we are going to begin with a polling question. If possible, please use a personal device to go to menti.com and enter the code projected. The code is still at the top of the screen if you are still trying to get into it. We're still getting some responses in, so I'll give it a few more seconds. Okay. So for our next question, we also have, do you have a family member or friend who has a diagnosed intellectual or developmental disability? I'll give it a few more seconds. So pretty substantial yes on both sides.
Yes, so thank you everybody for participating in that poll. And as you can see, many of you have close friends and family members in both the IDD and elderly communities. So now through our presentation, let's explore how these communities have been affected by COVID-19.
My part of the presentation focuses on the ethical implications of the COVID-19 pandemic for people with intellectual or developmental disabilities, also called IDD. I believe that how society prioritizes people to receive vaccines reflects the value society places on different human lives. Ableism, or privileging people without disabilities, has many implications for people with disabilities and the care they receive from many people in the medical field. Before we go deeper into this topic, I would first like to define IDD, or intellectual or developmental disabilities. As defined by the Eunice Kennedy Shriver National Institute of Child Health and Human Development, IDDs are disorders that are usually present at birth and that negatively affect the trajectory of the individual's physical, intellectual, and/or emotional development, and many of these conditions affect multiple body parts or systems. Because a large portion of my topic focuses specifically on COVID-19 vaccine allocation, I would first like to discuss the current procedures for distribution of the vaccine in the United States. Though the CDC has a recommended course of action for states to follow when it comes to determining vaccine priority, states are not required to use the recommended procedures. The Advisory Committee of Immunization Practices advises that frontline healthcare workers and those working in long-term care facilities should be provided with the first vaccinations, phase 1A, with frontline essential workers who are not healthcare and people over the age of 75 following in the next group, phase 1B. The next group, phase 1C, would include people aged 65 to 74, people aged 16 to 64 with medical conditions that increase the risk for severe COVID-19, and essential workers not previously included in phases 1A or 1B. Phase 2 would include all others over the age of 16. As for priority variation among states, we can look to California for an example. Because states have the liberty of determining their own procedures of vaccine allocation, vaccine distribution priority lists vary from state to state. California has recently decided to base their vaccine priority list on age as the sole factor after distributing to frontline healthcare workers. This liberty allows states to choose where they will rank the priority of certain groups, including people with disabilities. Overall, there is a noticeable trend of those with IDD being placed lower on priority lists than those who are not disabled and of the same age. Because those with IDD are at higher risk of contracting a serious illness as a result of COVID-19, it is important to provide necessary safety measures and precautions, such as the provision of the COVID-19 vaccine. The vulnerability of patients with disabilities to the COVID-19 virus is clearly demonstrated by the death and hospitalization rates. As you can see on the slide, patients with disabilities are 2.5 times more likely to contract COVID-19, 2.7 times more likely to be admitted to the hospital as a result of it, and 5.9 times more likely to die from the virus than the general population. The physical provision of the COVID-19 vaccine is not the only injustice that the IDD community has faced during this pandemic. Access to resources and safety measures may also be limited. For example, before anyone is able to receive a COVID-19 vaccine, they must register, usually online. Because those with disabilities could have a more difficult time using this technology, this automatically places them at a disadvantage for receiving the vaccine. They may require a caretaker who would need to assist them, meaning the responsibility for their safety is placed in another's hands. In a world where the autonomy of members of the IDD community may already be diminished, it is extremely important that we value patient autonomy and ensure that necessary medical resources are accessible. In addition, safety measures such as social distancing may not be possible in places such as group care facilities. If social distancing is not possible, how can all patients and the caretakers be protected? A patient with an intellectual or developmental disability in this situation might also not have access to safe social distance transportation, something else that could prevent them from getting medical care they need. While specific examples can be highlighted throughout the COVID-19 pandemic, ableism can be seen in the medical field as a whole. There's an overall breach of justice and responsibility by the medical field as a whole in considering prioritization of disabled communities. Ableism in the medical field can be very prominent in two areas: methods of allocation and acknowledgement of the IDD community in the first place. One instance of injustice regarding methods of allocation can be seen in triage protocols. Triage is essentially the process of determining who receives a resource based on urgency. Measures such as the sequential organ failure assessment and the quality adjusted life year aid in the determination of who will receive such a resource. And here's a chart with definitions of triage and examples of measures that are commonly used in triage protocols. Due to the misconception that members of the disabled community are assumed to have a lower quality of life, there may be instances where measures such as equality are impacted by this assumption. If quality scores are estimated to be lower due to lack of communication between patient and doctor and the assumption of a medical worker that a disabled patient has a lower quality of life, they may not gain the medical attention or resources needed. This also poses a threat to patient autonomy. Similar to the misconception about a disabled person's quality of life, there have also been cases where the perceived social utility of a disabled person has limited them from achieving treatment needed. This once again threatens autonomy. Lastly, there is an overall lack of acknowledgement of disabled communities in some areas of the medical field, as we have recently seen with the complete omittance of people with disabilities in vaccine priority lists. When disabled communities are completely left out of policies or procedures, such as vaccine allocation, greater confusion and miscommunication can lead to the further suffering of those with intellectual or developmental disabilities.
So my portion of the presentation will focus on how the COVID-19 pandemic has disproportionately affected the elderly community and has shed light on systemic issues threatening the safety and well-being of the elderly community. Additionally, it will explore the value of life as it relates to the allocation of scarce resources, specifically in relation to the elderly. So what exactly is ageism? Ageism is discrimination against the elderly/older adult community because of their age. There are many forms of ageism that include stereotyping, neglect in the medical field, abuse, and belittling. The elderly are most frequently recognized as anyone over the age of 65. So ageism is not a new concept. Rather, this form of discrimination has been prevalent for years before the pandemic. In the past years, younger generations have been expressing their political opinions more passionately as issues have been rising. There's been an increased stigma made by the younger generations that portray the elderly in a negative light because they may not agree with their opinions. The clashing of old and new opinions has created terms such as "okay boomer," which disrespects the baby boomer generation for their beliefs and values. The US National Academy of Science has defined elder abuse as A, intentional actions that cause harm, whether or not harm is intended, to a vulnerable elder by a caregiver or other person who stands in a trust relationship with the elder, and B, failure by a caregiver to satisfy the elder's basic needs or to protect the elder from harm. Additionally, 1 in 10 Americans above the age of 65 have experienced some form of elder abuse. That number has been estimated to be about 5 million per year, but only about 1 in 14 cases of elder abuse are actually reported each year. Additionally, aging can cause a series of problems as the body is more worn down. For example, a disease that can be present in older adults is Alzheimer's, which is a form of dementia that destroys mental function and memory. This can lead to vulnerability towards the end of life. Recently, the Abuse of People with Dementia Representative Survey was conducted through interviews with dementia patients. It was reported that 52% of those patients reported some type of abuse in the last 3 months. Another prevalent form of frequently seen ageism is the neglect of the elderly in the medical field. Yale School of Public Health recently conducted a study that revealed that ageism in the medical field against individuals who are above the age of 60 is responsible for 17 million cases of the 8 most expensive illnesses, which in total adds up to about $63 billion per year. In its essence, this means that neglecting patients because of their age leads to increased intensity in diseases, which can lead to additional spendings. Additionally, through thorough care, diseases can be prevented early on, but neglect can prevent this from happening. As you can see here, the elderly population is among the most vulnerable during the COVID-19 pandemic. In this statistic, the comparison group is 18 to 29 years old. And for the 65 to 74 age group, they are 5 times more likely to be hospitalized and 90 times more likely to die. The 75 to 84 age group are 8 times more likely to be hospitalized and 220 times more likely to die. Lastly, the 85 plus age group are 13 times more likely to be hospitalized and 730 times more likely to die. COVID-19 has been able to bring to light many systemic issues in American society relating to the treatment of elderlies and further create issues for this community. An example of ageism has been the clearing the deck mentality. When caring for patients in a time of crisis, such as the COVID-19 pandemic, not every patient can be saved. This is a fact, yet many healthcare professionals have been using a rather ageist/utilitarian outlook on this issue. This issue has been prevalent among the elderly community because healthcare professionals have been trying to maximize the maximum number of lives being saved, and this comes at the expense of the elderly. 2 methods that contribute to clearing the deck are the SOFA score and Qualis. As previously mentioned, the SOFA score, or Sequential Organ Failure Assessment, is a triage tool used by hospitals that are operating under crisis standards of care. It provides a way to evaluate patients on 6 parameters and judge their condition relative to other patients. Qualis, or quality adjusted life years, are rates that are calculated to measure how intervention, from medical treatment can extend and improve quality of life. Both of these methods create a negative outcome for many elderlies. The treatment that arises with Qualis is that it uses life years ahead and quality of life to determine if a treatment is suitable for a patient. If a treatment is being compared on a younger adult and elderly person, the elderly person will have fewer Qualis, since they have fewer years ahead of them and potentially a lower quality of life due to age-related comorbidities. Additionally, a question that I was wondering is, can quality of life truly be quantified? Next, the issue that arises with the SOFA score is that this method works by comparing the current state of a patient's organs with their potential for using the resources in the long term, and that is a tool to allocate resources. This method favors younger patients because if a patient is older, their score will be higher, since they may not be able to live as long as a younger patient could. They also may have more comorbidities, which additionally will raise their score. With using the SOFA score, higher scores are placed in groups that are last to receive resources such as ventilators. Another form of discrimination has been the vaccine production and clinical trials with the COVID-19 vaccine. With the numbers of COVID-19 cases constantly rising, it has become increasingly important for a vaccine to be produced, and thankfully many have been. In the past, older adults have been excluded from vaccine trials and other clinical trials, and to combat this, the National Institutes of Health implemented the Inclusion Across Lifespan policy, which requires that older adults must be included in clinical trials. A study was conducted to see how adults above the age of 65 would be excluded from 847 clinical trials. After examining many clinical trials, they were able to estimate that about 50% of older adults above the age of 65 are likely to be excluded from COVID-19 clinical trials due to high selectivity based on age and health. One recent study even revealed that the median age for their clinical trial was 40, which concluded that there is most likely not individuals above the age of 75. Many of these companies that are producing the vaccine argue that they do not want to run the risk of hurting older individuals with clinical trials, and that herd immunity, which is 67%, can be reached without vaccinating the young. This is true, but in places such as nursing homes, all of the individuals must be vaccinated to keep everyone safe, since they are all vulnerable. Additionally, not including them in trials means that later on, there is uncertainty on how the vaccine will affect them. As adults age, their antibody response may decrease, which means that not testing them with the vaccine before distributing it could lead to issues. So a question that we can all think about is, when prioritizing people to receive scarce resources, should we focus on their long-term life expectancy if they receive the resource, or their short-term ability to survive without it? So how has COVID-19 truly changed the lives of elderly individuals? COVID-19 truly has changed the lives of the elderly community because they've been extremely isolated from their friends and families. And this has led to an increase in mental health issues and additional casualties. For example, let's focus on Chester Pesky, which is the picture listed on the screen, and he was 98. Although he had Alzheimer's, he was a very happy guy. The COVID-19 pandemic occurred and he did contract COVID-19, but survived and was completely asymptomatic. But after months of self-isolation and no contact with his family and friends, he slowly started to decline, and he became increasingly depressed. This mental drain of being alone, coupled with Alzheimer's, sped up his decline, and before his family could even get to him, he passed away. He had survived COVID-19 and was living with Alzheimer's, but social isolation ended up taking his life. Before the pandemic, it was estimated about 20% of elders experienced some form of mental illness. And by looking at this graph here on the right, it's apparent that the numbers are only rising due to COVID-19. With this information, it is becoming clear that elderly need to be vaccinated and granted resources they need to preserve their mental well-being.
So our main ethical question is, what is our duty to vulnerable people in a public health crisis? Through our research, we have come to the conclusion that elderly people and people with disabilities should be prioritized during a public health emergency.
Through our research, we have come to the conclusion that when it comes to vaccines and ventilators alike, since these groups are the most vulnerable, they should be prioritized. They should be granted the access they need to vaccines first, and when it comes to allocating scarce resources, since these groups are extremely vulnerable, they should receive them, as it is unclear if they can live without a necessary resource such as ventilation. Now we will dive into the stakeholders, values, and frameworks that helped us come to our conclusion.
In our main ethical question, we saw the need to highlight 5 stakeholders that play a key role in this ethical situation. First, and most importantly, are the patients themselves. Many of these individuals' lives are being risked daily, and as explained earlier, they can be more vulnerable. The denial of resources could cost them their lives. Next are doctors. An immense amount of pressure has been placed on themselves and triage teams who have to decide who gets scarce resources. Additionally, healthcare professionals who are developing clinical trials and vaccine lists are being affected by each decision as well.
Next, we focus on caretakers. Many of these individuals in both the elderly and IDD community have been one-on-one with the caretaker, and the burden of COVID-19 has directly affected them as well. Similarly, with families, watching their loved ones continually suffer through this pandemic has been extremely painful. And lastly, with families with a member over the age of 65 or with an IDD, they are relying on healthcare systems to protect and care for their loved ones. The government is funding many programs such as Medicare, which helps adults above the age of 65. The cost of paying for this group is directly affecting the economy and government. Now we're going to discuss the 3 main values that we see as most important when discussing resource allocation and priority for vulnerable populations. The first value that we both looked at was responsibility. When looking at the elderly community, responsibility means that healthcare professionals have a moral obligation to help the most vulnerable. Once again, this goes back to my previous question of, when prioritizing people to receive scarce resources, should we focus on their long-term life expectancy if they receive the resource, or their short-term ability to survive without it? During this pandemic, and when thinking about ventilators, for example, it's vital that we focus on short-term survival to protect the elderly community.
The health of patients with IDD and elderly patients lies in the hands of medical professionals and the government, among other stakeholders. The right to health must be protected for all patients, including those with IDD. Efforts must be made to uphold this right for those who rely on others for care and for health.
Next, we looked at safety. For the elderly community, safety means that neglecting the most vulnerable will lead to an increase in preventable mortalities among vulnerable populations. Statistics show that elderly populations are among the most vulnerable, hence why they need to be granted equitable access to ventilators specifically for their own safety.
Saving the lives of those most at risk is a vital part of determining COVID-19 procedures. Because those with IDD are among groups that are severely at risk, their safety must be valued.
Lastly, we looked into equity, which in our situation means that each patient is individually treated and granted their own needs. For the elderly, equity means that each patient should be granted the care that they specifically need. The most severe should be prioritized when it comes to specifically to ventilation because their needs need to be met for survival.
As demonstrated by the statistics shown earlier, patients with IDD are more likely to contract COVID-19, become hospitalized for it, and die as a result of it. An equitable approach must be taken when discussing access to life-saving resources, meaning the most vulnerable would receive such resources first. For example, equitable distribution of the vaccine to groups disproportionately affected by the virus, such as disabled communities and elderly communities, would work to lower the number of deaths due to COVID-19 by vaccinating the most vulnerable. Those living in group care facilities or with a caretaker may not have the ability to social distance, for example, while those living alone or living with families do, so providing the vaccine to these groups would help to save many lives. And now we would like to pose a question to everyone else. After looking at the values on this slide, would anyone like to share any other values they feel play a role in these situations or an alternate perspective of one of the values projected?
And if not, also just turn to a partner or think to yourself about what possibly the counter arguments could be for these values. And if you guys have any other ideas about these.
We have a comment from Ms. Goldman suggesting empathy.
Thank you, Ms. Gold.
Yeah, thank you. We also definitely looked into that as well. We were thinking about empathy and thinking about how, for us specifically, we all have noticed how difficult the pandemic has been just in general. And then once you go the next step and use empathy to think about how the elderly and IDD communities have been affected, it's pretty hard for us because thankfully, a lot of us have been able to stay home and we've been safe with our friends and families. But unfortunately, Many of these communities have been isolated and haven't been able to spend time with their friends and family, so it's just very hard to put ourselves in that position.
Okay, so moving on to our frameworks.
So the framework that we saw most prominently in our topics was consequentialism, which focuses on justifying if something is morally right or wrong by looking at the consequence of the actions. When thinking about ageism and scarce resource allocation during COVID-19, it is necessary to consider the framework of consequentialism. If ageism is justified during the pandemic, such as denying care and/or resources solely based on age, the down-the-line trust will be broken between the medical field and elderly population. If both younger and older generations see how the elderly community was denied care, they may not have the same trust with healthcare professionals going forward. They may fear that they will not get the equitable care that they deserve once they age. And continuing on, also, additionally, the 50-plus age group are large contributors to the economy. In 2018, the 50-plus age group contributed $8.3 trillion to the economy. So the emotional and economic effects of neglecting the elderly will have severe effects currently and for years to come.
I believe that consequentialism also has an impact in the short term, depending on how it is perceived. One perspective of consequentialism would state that the most ethical course of action would be to vaccinate as many people as possible, as fast as possible, regardless of need or urgency. This fails to consider those who are most at risk of contracting the virus and becoming hospitalized as a result of it, and therefore would not be a strong ethical framework in this scenario. The alternate viewpoint of consequentialism would be to vaccinate those most at risk, therefore eliminating future hospitalizations and cases.
Additionally, we looked at the application of deontology. Deontology is defined as using a set of rules to determine the ethicality as opposed to the consequences. For the elderly, deontology means that instead of looking at long-term survival, short-term survival should be prioritized. The most severe patients should be handled without thinking about their long-term survival after. Many triage teams work to maximize long-term survival, but there are fallacies with that course of action. The main issue is that no life is guaranteed to be lived. For example, if doctors were trying to determine if a young adult or older adult should get a scarce resource, such as a ventilator, many triage teams would encourage that the younger adult would get this resource as they most likely will be able to live longer. This is not a guarantee though. Additionally, the older adult would most likely be in a more of a critical state because they are more susceptible to getting an age-related comorbidity and being negatively affected by COVID-19, meaning that it is vital that the older adult is allocated the resource.
I believe that deontology would also benefit my argument by creating of rules that, for example, would state that groups such as disabled communities must be specifically listed on vaccine priority lists. Even if placed lower on lists than what I consider ethical, disabled communities would have knowledge about when they would receive a vaccine and where they're on the list they are located. Such rules could also work to ensure that these incredibly vulnerable groups are provided with life-saving resources during first waves of allocation. With this being considered, I also acknowledge that there are issues with a completely deontological perspective of this issue. Deontological rules do not leave room for exceptions, something that is important in triage protocols, vaccine distribution, and medical rationing. This can be harmful for those that are in dire need of a resource, vaccine, ventilator, etc., but are not allowed to get one at the time according to the rules.
So to broaden our perspective of this prevalent issue that we are seeing in society of who or what is priority, we decided to look at a counter-argument to our original perspective. To explore this argument, we looked at utilitarianism, which is the framework that states that actions are right if they benefit the majority. For the elderly, I looked at private versus public health and concluded in my counter-argument that private and individualized health cannot always be prioritized in a time of crisis. In a recent study conducted by a triage team, it was concluded that the elderly community does have a lower chance of recovering from infectious diseases and viruses, such as COVID-19, which places them in a lower prioritization group. Valuable resources could be wasted if private health is prioritized. When resources are scarce, long-term survival needs to be maximized because resources need to be shared among a large group of people. For example, an elderly person may require more time on a ventilator, which can end up limiting the amount of other people able to use it, which could result in additional fatalities.
I believe that utilitarianism also poses counter-argument to my position. This alternate perspective of the argument is that providing the larger non-disabled community with the vaccine inadvertently benefits disabled communities. If more people have received the vaccine, the spread would slow and cases would begin to go down due to herd immunity. Less people would contract the virus, meaning less people are able to spread it. Although this could be a valid perspective, it does not solve the ethical injustice at hand. In our society, those with disabilities are unfortunately not seen as equal to those who do not have disabilities.
Additionally, we looked at the value of equality to counter our previous argument, which was equity. I concluded that in a time of crisis such as the COVID-19 pandemic, to eliminate biases, equality must be maintained. Each person should be treated equally to maximize the lives that can be saved. It's evident that not all lives can be saved, so each person should be granted equal access to care, but not guaranteed extra support.
In thinking about allocation of the vaccine, as I stated previously, I think an equitable approach would be more beneficial and ethical than an equal approach. For example, equitable distribution to groups disproportionately affected would work to lower the number of deaths due to COVID-19 by vaccinating the most vulnerable. Equal distribution would mean that all groups would be provided with equal access to the vaccine, therefore disregarding concerns of necessity or vulnerability. An equal distribution would not aid these vulnerable groups.
So in conclusion, we believe that in a time of crisis, vulnerable groups such as the IDD and elderly communities should be prioritized.
From our perspective, priority for these groups during this pandemic means that IDD and elderly people should be placed in the top vaccine group and should be granted scarce resources such as ventilators over the general population. Lastly, we have some further questions that we are still wondering about and that we would like to pose to you all. Regarding my portion of the presentation, I was wondering, should any factors within determining vaccine priority lists be considered above else, for example, age, health status, etc.? Also, is the lower priority placement of disabled communities a matter of eugenics?
The elderly community, I was wondering, how can the US care for and protect both the younger and older people in our society? Also, what are the long-term implications of the US clearing the decks of older people? And along with that question, adding on to it, will there be fewer older volunteers for clinical trials? Additionally, will broken trust and fewer clinical trial volunteers affect our ability to give older patients quality health care? Thank you so much for attending and listening to our presentation.
We are now open to answer any questions that you may have.
So thank you, Alana and Lizzie, for that very interesting presentation. So we have time for a brief Q&A period, or if you have any comments on the questions that they just posed, feel free to raise your hand or come up to the D10 if you're in a classroom, and I will call on you to share. And as a reminder for remote viewers, if you have a question and you have access to the chat box, please send your question privately to me by selecting Moderator Georgia, and I will give your questions to our presenters. Thank you. Okay, see, there's a question in the library, so go ahead.
You guys might have already mentioned this, but I just think it's also important to take into account how younger people who are not part of the disabled community or the elderly community may have underlying conditions that determine whether they survive or not in a pandemic like this. So I was just wondering, are you guys saying that those people are not as important as the elderly and disabled? And when things like that overlap, where do you guys draw the line and determine which community should be most prioritized?
Lizzie?
Yeah, so I can start off. So originally when Alana and I were paired together, the first thing that we thought about is the creation of like a social hierarchy in medicine. So I think, referring to your question, I don't think that any one group is more important than the other. And I think that during this time, I think it's just most important that all of those people, elderly, IDD, any younger people with underlying conditions, are pushed to the front of like vaccine priority lists and also for receiving resources. So I don't think anyone is more important than the other. Rather, all of them should be treated equitably above the general population.
I completely agree with Lizzie. I think it really just all comes down to the vulnerability of each of these groups. And again, like we're not considering one group the most of utmost importance. It's more of an effort to acknowledge all of these disparities that some of these groups suffer from and working to create an equitable approach in order to account for all of it. And thank you so much for your question. If no one has any other thoughts or questions, I can also project the questions that we asked ourselves back up on the screen for your reference. Give me one moment.
Oh, and also it seems like US 148 has a question. Caitlin, go ahead.
So I had a question. How did you guys choose the topics that you were going to focus on?
I can start first. So originally when I was thinking about COVID-19 in general on this project, I was trying to think about kind of populations that are almost brushed by, like not always focused on. And we've heard like a lot of talk about the elderly population and how they've been extremely vulnerable. But I want to kind of get to the root of the problem and understand why this actually was occurring and what actually prompted this to become such an issue. And specifically looking at other countries such as Italy, who had a real problem with their elderly community and balancing COVID-19. I really just wanted to get to the root of the issue and figure out how like years of systemic issues have built up to this moment.
Yeah, when we were coming up with these topics, it was kind of earlier in the year, back before vaccines were released to the public, back when everyone was still going through their clinical trials. So that was when, for my personal inspiration for this project, it was more of when the question of who will be determined priority when the lists were just beginning to come out. And I just saw a lot of inconsistency between some groups, especially among states such as California, as I stated before, that it really just wanted to make me look into which groups are being placed higher in some, which groups are being placed lower in others, and looking into the inconsistencies between those.
Yeah, and I also think it's interesting to add that when Alana and I were starting our research back in November, for many vaccine productions, there wasn't a lot of information. And by now we have a lot more information about like who actually is in that first group and like a lot more information about like triage and methods of allocation. So it was just very interesting to watch everything actually happen in the news as we were researching it.
I'm going to pull my screen back up just so you can see our questions for reference if anyone would like to respond to these.
Okay, and I see a question, another question from the library.
Hi, I know this wasn't really what your presentation focused on, but do you think your sort of perspective that those who are hurt the most should be put to the front of the line per se should also apply to the case of like developed and developing nations in terms of vaccines, and that those nations that are hurting the most should be given vaccines first? Does that sort of carry over?
Yeah, I think that for me, I mean, Alana, you can definitely speak more. This is more your project, but I definitely think that should be the case. And the reason that I'm thinking about that is because, especially in those developing countries, they don't necessarily always have access to equitable care. And like they don't always have the option to be able to social distance and wear masks always. So I think that it is important that there is a pressed importance on those smaller countries to getting care and getting vaccines, just because they don't have all the luxuries that many of us do have.
Yeah, I agree. I know that this is talked about a lot in Anira's presentation, if you have the chance to go talk to her after this. But I believe that there is more of a collective like social responsibility. And I do think that that extends internationally when looking at some countries that may not have access to all of these resources. So that's a really interesting point to consider. Thank you.
Okay, and I see a question from 148.
My question is, as we grapple with the graying of America, which really deals with the older population becoming a larger demographic, does that impact who we think of as elderly and who gets priority with things like vaccines?
Yeah, so definitely. So I did do a lot of research on that area. And I think a lot of the problems that are arising with the increase in our elderly population is that like for many groups, we're not necessarily putting as much of an emphasis on our elderly population. Since before, like I was looking at other countries such as like India and like South Korea. And in both of those countries, they do have a smaller elderly population. And culturally, they all believe that they put like more of like a stressed influence on the elderly population and protecting them. And now in America, since our elderly population is growing so much, I think that is playing a role here in the increased ageism that we're seeing and the increased stigma around the population.
Okay, so I have a question from Tara. She's wondering what are some of the long-term implications of clearing the decks for younger people? So like, what are the implications that will last for younger people?
Yeah, I mean, I talked about this before in my presentation, and if we clear the decks of the older people, there could be an increased stigma. And I think the same thing goes for clearing the decks of younger people. So if we put such a stressed influence on saving our older population, potentially we could be losing out on younger generations. And going forward, I mean, the younger generation is the future. So if we don't prioritize them, then we could lose future workers. But in my argument, I did talk a lot about how most of the elderly patients are usually in a worse condition compared to younger adults. And it just, I believe personally that we should put a stress influence on curing for the most sick rather than curing for long-term life expectancy. But it is definitely an argument to think about.
Okay, thank you. And I think we have time for one more question. So that question is, so given all the research you both have done and all the facts you've uncovered, which single event would you consider to be the most positively impactful to address like the issues you're talking about?
That's a very good question. So thinking about the question was like an event that is very positively impacting either of our situations. I think the amount of vaccines that have been able to be produced and distributed to the general population, I think that over the past few weeks and months, we've seen a huge increase on the number of people who are able to have gotten vaccinated or who are currently in the process of being vaccinated. So I think that that is just a really positive event happening, both regarding this situation and in the situation that our country's in as a whole. And it's really uplifting to see.
Okay, and I'm going to try and squeeze in one more quick question because I think it's really interesting, and then we'll close out and head back to the closing remarks. But so from Miss Bishop, I have the question. So you ask what will be lost if older people are allowed to die. Native American peoples in the United States were quoted as saying they prioritize older people for the vaccines and care because they are a source of knowledge about traditions, culture, and language. And without them, this knowledge would be lost. Oh, so actually not a question, a comment, but a good comment, very interesting. And just to add to like your argument overall. And I think that's a great way to close us out. So I hope everyone enjoyed this workshop, and great job to Lizzie and Alana. And now we'll be heading immediately into our closing remarks that start in 2 minutes. So head on over to the associated Zoom link for that. And I'll see you there. Thank you and great job.
Thank you so much, everyone.